Let me go into the second case, which is kind of an interesting case. This is a 31-year-old male. He actually underwent ultrasound, not ordered by me, because of a very strong family history of thyroid cancer and was found to have thyroid nodules. He's totally asymptomatic, no radiation exposure. His past medical history, he had a osteochondroma of the humerus, which has not been treated. It's been monitored. The family history, I don't mean the SH, but it's a family history. Father, mother, sister, and a brother all had PTC. I operated on the mother and the sister's primary tumors and the father's recurrence, just an FYI. So examination, completely normal exam. No thyroid nodules, the thyroid's not enlarged, no lymphadenopathy. So here's what his ultrasound looks like. This is a right-sided thyroid nodule, really unimpressive looking, as you can see. It's hypoechoic, not even a capsule around it. Just a couple of the transverse view, perhaps you can see that maybe there's like this looks like possibly just a small cystic lesion with perhaps a small solid projection. I don't know if there's a pointer here, but just up at about 11 o'clock, as you can see there. And the other contralateral lobe, there's a 3 millimeter nodule there. So nothing very exciting. So at this point, he ends up in my office. So what do I do? What do you do with this gentleman?
Well, my suspicion is if he got as far as your office, he may want you to biopsy something. So my question is, would you agree to do that or not?
Well, that's what I'm asking you.
So I would, again, this come down to conversations with patients, and clearly this is a patient who appears to have meet criteria that justifies suspicion for familial papillary thyroid cancer. Having said that, all of the lesions you have seen are relatively benign in appearance, and certainly I think the largest one was just a centimeter in size. So without the family history, I would not have biopsied this patient. But with the family history and what I suspect is a high index of concern and anxiety by this patient to have come as far as he's come, I suspect a biopsy may be in his future. Considerations when you're dealing with familial papillary thyroid cancer are different than those of sporadic papillary thyroid cancer. The most recent data I've seen are from Pinto in 2013, where patients with familial papillary thyroid cancer are significantly more likely to have multifocal disease, so bilateral disease, and also disease that is extrathyroidal, so more extensive disease. So those would be two things I would have in the back of my mind.
Okay. Well, so exactly what you said. So the right-sided thyroid nodule was biopsied under ultrasound, and it was suspicious for papillary thyroid carcinoma, Bethesda 5. So at this point, even though he's so anxious, he asked me, well, it's not really cancer. Do I really need surgery right now? And is there any other tests that you can do to help me make up my mind? What would you tell the patient?
Well, I would do...
No, go ahead.
Please.
I'm someone, obviously, because I have to disclose I'm a member of the American Thyroid Association Guideline Writing Committee, so since I helped to write guidelines, I believe in guidelines, and I believe in the evidence that supports them. The guidelines would suggest that patients with a suspicion for papillary thyroid cancer, based on the Bethesda classification publication, show a malignancy rate of 60 to 75%. And the management of a thyroid nodule that is suspicious for papillary thyroid cancer should be treated as if it were a papillary thyroid cancer. If you actually look in nodules that go on to undergo resection, the largest systematic review I've seen puts the risk of malignancy at about 70%. So, you know, I probably would approach this patient pretty certain he has papillary thyroid cancer, and I am not sure that the cost of additional testing would necessarily change my management, A, with regard to surgery, no surgery, or B, if we're thinking about a rule-in test, necessarily the extent of surgery. You know, for micropapillary thyroid cancers, I absolutely think that lobectomy is adequate, but this is potentially a familial papillary where I'd be concerned about bilateral disease.
Okay, but before I go on to,
May I comment on that?
so let me just give you additional information, okay? So I had just operated on the mom, and this is her pathology. So multifocal, and you can see its largest tumor is 1.4. Lymph nodes were all negative. The sister had a 1.2 centimeter PTC, and 11 of 30 central neck nodes were positive. We're not going to get into the debate of why I did that. So I'll leave it at that. So given this additional information, does this change how you would manage this patient, Bob?
Well, you know, I'm going to be a little provocative here. I would actually, on this patient, be interested in molecular alteration testing panel. And that would include like a BRAF, red PTC, a RAS, and red Paxate PPR gamma. So the reason I want to know that, okay, sure, it's suspicious for thyroid cancer. You're going to operate on it. It's Bethesda 5. You have a family history of thyroid cancer. But I think that what that result turns out to be is going to maybe influence me. And so let's say that we did that test, and let's say it's BRAF positive. Okay, so now you know you have thyroid cancer. You're not 75% sure, you're not 60% sure. You know you have that. And then your decision is not, am I going to do lobectomy or am I not going to do lobectomy? Your decision now is, am I going to do lobectomy or am I going to do total thyroidectomy? And you could say that basically this is a large microcarcinoma, you know, or a small T1, it's 1 centimeter. And there would be a lot in me that would want to resist doing a total thyroidectomy for a patient like that. So, you know, why is BRAF going to change that? And here's where I'm being a little provocative. If we look at what the party line is in 2014, there are no prospective good studies that would suggest that we should use molecular alteration testing to change our management or to suggest that in an individual patient that changes prognosis. However, and let's draw back, if I could just extrapolate on where that kind of position has come from. You know, all of this stuff is within 5 years. And if you look at Jing's paper in 2009, Nikiforov's paper in 2009, the initial feeling was BRAF was a very aggressive tumor with a higher rate of recurrence, thyroidal spread, and metastases. And then you would have manuscripts that were multivariate analysis by Howell et al. And Lee, L-E-E et al., who also suggested this was the case. But then you had some backwards on this, including your paper. You wrote a paper that showed there was not a higher rate of central nodal disease with BRAF positive. A lot of people did. The Korean group led by Kim et al., the Japanese group, Portuguese group, Italian group, Lee L.I. et al. Also suggested that on multivariate analysis there was not a higher risk factor. So we got this sense of confusion about BRAF, and so in 2014 we're sort of sitting there going, well, we shouldn't really use it that much. But there's also some very scary things about BRAF, and the reason there's confusion with BRAF and what to do with it is that 4 out of 5 times a BRAF positive test, the tumor does not act aggressively. The problem is 1 out of 5 times it really does. So that if we look at the work of Rivera here at Memorial, and he looks at follicular variant of papillary thyroid cancers, if they're BRAF positive, they tend to be infiltrated. If they're RAS positive, they tend to be encapsulated. If you look at the work by Tufano, when he has recurrent papillary thyroid cancer in the central neck, 75% of the time, it's BRAF positive. If we look at Baralo's work, when you get a BRAF positive recurrence, it tends not to be radioactive iodine, which led Nikki Foroff to write a review article that suggested we ought to be more aggressive with BRAF positive nodules when they're still radioactive iodine avid and not wait till they become not avid. And then if you look at work by Tuttle, who shows that if you have a metastasis from a papillary thyroid cancer, and it's, say, RAS positive, it tends to be radioactive iodine avid. If it's BRAF positive, it tends to be radioactive iodine non-avid. And then if you look at 4 different studies by Zhu and Lin and Wong and Niemeyer, microcarcinomas that are BRAF positive tend to be multicentric, tend to be on both sides, and they tend to have central node metastases. So for those reasons, that would make a difference to me on thinking about what to do with this essentially microcarcinoma. So that I personally am very reluctant to do a total thyroidectomy on a 1 centimeter thyroid, papillary thyroid cancer. But if it's BRAF positive, that's going to shade me. And that, coupled with that family history, is going to shade me on
Right.
what I'm going to do.
Well, so after his, family's tests came back, path came back and everything, we had long discussion about the pros and cons of hemi versus total and factor everything in. And he actually elected for a total, and he had multifocal disease. So, and in both lobes.
And I would just reiterate, in the setting of a familial papillary thyroid cancer, that is like an irradiated thyroid gland. All of that gland is at risk for the development of papillary thyroid cancer, and the current guidelines are for total thyroidectomy. Now, the guidelines are evolving, and there's going to be a lot more tolerance, exactly as you said, for lobectomy versus total thyroidectomy, but that's in a non-familial setting. That's in the setting of low-risk papillary thyroid cancers, which actually can be defined to be as large as 4 centimeters.
Very good. So I think these 2 cases illustrate the different tests that are available and the different cytologic findings, and I think it's important for you all to understand the indications of when you use these tests. So I'm going to have Dr. Witt come up and just sort of summarize the gene expression classifier in about 7 to 10 minutes, and then Dr. DeSosa is going to summarize the molecular alteration panels that are available and its utility and when you might use that to make your surgical decisions.